is an examiner of the FIPP and CIPS. So for those of you who would like to take this exam, be nice to him because he's one of the examiner. He's also the director of the Taiwan Pain Society and a founding member of the World Institute of Pain in Taiwan section. He's the chairperson of the Committee of Pain Medicine, Taiwan Society of Anesthesiologists. So today we are privileged to have one of the best doctor for pain, not only in Taiwan, but in different parts of Asia and in the world, who will share to us a very important and relevant topic on pain physicians' approach to pelvic pain. And he is no other than Dr. Chih Peng Lin, an anesthesiologist in Taiwan. But before we begin, as we usually do it, we will pause for a moment for a prayer. So let us pray, everyone. Heavenly Father, we come before your presence today. We thank you in this Zoom meeting. We are facing challenging times, but because of your grace, but because of your goodness, we are still experiencing your goodness and your grace, and you have preserved our lives up to this day. We would like, Lord, to pray for your guidance, especially as we listen to a lecture that will be shared to us by Dr. Chih Peng Lin. Give him the wisdom that he needs in order that we may be able to understand what he's sharing to us. Can you be with the rest of the participants today? And we ask, Lord, for your Holy Spirit and your guidance. In Jesus' name we pray. Amen. So ladies and gentlemen, I would like to welcome Dr. Chih Peng Lin. Okay, Patrick, go ahead. You are now the speaker.
Okay, thank you. Good morning, everyone. I checked the participants. Seems there are any new friends and old friends here. And I would like to express my gratitude to Jim. Thank you very much for having me to join this fantastic online meeting. So it's my privilege to chat or to discuss with you a quite challenging topic. It's pain physicians' approach to pelvic pain. I'm sorry, I had no disclosure before my talk, but I would like to express, because of my training, I tend to do some classical interventions under floral guide, but more and more of my practice is now under ultrasound, or even it's the dual image or even multi-guidance guided complex procedure. So I'm not purposefully do this, but before I can very confident with all my ultrasound procedure, I always check under floral to confirm my level, my depth, and my precision. So, and I would like to share some of my experience with you. I'm sorry, it's a COVID-19 pandemic. So yet, up to yesterday, we have more than 10 million people suffer from this illness. And we have more than 500,000 mortality. So it's a tragedy. However, in the world, we have a country, up to yesterday, we have only 447 confirmed cases throughout our nation. And we have only 7 mortalities. So Taiwan probably is the safest country in the world. So where is Taiwan? Before I start my talk, I would like to briefly introduce my lovely country. It's over here. So it's in between Philippines, Southeast Asia, Northeast Asia, Japan, and Korea. So we are here. And you know, the COVID-19 start from China, and we have less than 100 miles away from China. So we try to keep our border safe very hardly. We are not a big country. So in terms of the land area, we are 36,000 square kilometers. In terms of population, we have around 23 million. So we are densely populated. And you can see we are a mountainous country. So you are welcome to visit Taiwan after this COVID-19 pandemic. We have beautiful skyline with metropolitan area. I want to mention it's the east part of Taiwan. We have very beautiful landscape. Like within 5 kilometers, the altitude from 3,000 meters down to the sea level. So you can see very beautiful cliffs. And we have many cultural things. And I know somebody might know we have very famous cuisine like Din Tai Fung. Okay, and I would like
Okay na.
to.
Pakiabot na lang kay, ay, yung payment pala dito sa akin nakalimutan. Yung injection fee na lang.
Hello, can you hear me?
Yes, go ahead, Patrick.
Okay.
Go ahead.
Okay, so I would like to introduce my university for a little bit. National Taiwan University was founded back to 1928. Because of the historical issue, at that time, Taiwan was part of Japan. So we are the number 7 imperial university before Second World War. So when we set up the school, we are very famous in agricultural, politics, and science, especially medicine. And we are the best university in Taiwan. According to the updated QS ranking, we are number 66 in the world. So we are number 20 in Asia. So it's our campus. The College of Medicine is even older than our university. So at that time, we are founded back to 1897. So it's our original building. It's beautiful. And it's the initial entry for our outpatient section. So it's built up in 1925. And we moved to our main quarter hospital just across the street in 1991. So in the headquarter hospital, we have more than 2,600 acute care beds, and we have more than 300 intensive care unit beds. So we are a huge complex hospital, and not only the headquarters, we have many branch hospitals in Taiwan. As Jim said, our College of Medicine has become one of the official sites for World Institute of Pain. So each year, usually at January, we will host WIP Interventional Symposium Workshop and the FIPP CIPS examination. So this year, fortunately, we completed at mid-January. So at that time, the world is safe. Okay, so let me go back to my main topic. It's pain physician's approach for pelvic pain. It's kind of tough. At the initial time I started my pelvic pain practice, for me, it's just like a chaos. So because it's so vague and the painful area is so embarrassing, so I have to have many conversations with my urologist colleague. So we have to, discuss about something I'm not so familiar. In terms of my training background, I'm an anesthesiologist by training. So my thinking is always, the patient has some pain that I numb it, or I just put them into sleep. But if you are dealing with the complex disease, then you should know some details like a UDS, urodynamic study. And also we have to have very close relationship with gynae. And to be honest, I even try to learn some transvaginal ultrasound to do my nerve block, but it's a little bit cumbersome. So now I just gave it up. Let us do some numbers. In terms of the epidemiology, up to 15-20% of female patient aged between 18 to 50. So it's the most productive age. The female patients suffer from pelvic pain. And for male, it's even more complex because it's less well-defined. And not to mention, after inguinal surgery, up to 35% of patients will suffer from chronic pelvic pain. So it's a big issue because inguinal surgery is quite common everywhere in the world. So let me do some terms. By definition, pelvic pain means the pain arises from visceral or somatic system encompassing structural supply by the nervous tissue from T10 and below. So remember our dermatome for umbilicus, it's T10. So below T10, we define it as pelvic pain. And pelvic pain syndrome, the syndromic constellation of symptoms, it's a recurrent, persistent pain associated with symptoms suggesting the involvement of the musculoskeletal, gynecological, gastrointestinal, and urological system. And in the absence, so there's no significant inflammation or other specific pathology, then we will call it as the pelvic pain syndrome. And if the duration is more than 6 months with non-malignant origin, then we will call it as a chronic pelvic pain. And by definition, the pelvic floor means the facial and muscular layers that span the bony outlets of pelvis. So it's the bottom of our human body. It's pelvic floor. And pelvic floor dysfunction is quite common among chronic pelvic pain patients. So the differential diagnosis for chronic pain, it's very tough. But before we do any decision making, we should always rule out red flag symptoms, red flag disease like malignancy, infection, occult trauma, especially maybe abuse related occult trauma, and the major vascular lesions. Some of the intrapelvic vascular stenosis can cause the symptom like chronic pelvic pain. It's very common in aged population. So anyone remember our visceral somatic convergence concept? It's very important in diagnosing or planning your interventional procedures. So because pain originating from sacrosympathetic segments, the patient will experience the pain in sacrosomatic region and vice versa. And the visceral efferents that ever reach upper lumbar low thoracic spinal cord, it's actually at the same level of visceral fiber from lower lumbar disc, lower lumbar disc lower lumbar disc. So it making differential diagnosis is quite important to differentiate the pelvic pain and the lower lumbar problem. And the somatic convergence from autonomic efferent leads to somatic symptom. So the pain transmits in through the autonomic fibers. Then the patient can sense maybe it's a refer pain pattern in the somatic distribution. At the same time, if it's the somatic pain that transmit the pain signal back to spinal cord, and you can have vague refer pain like it's it's visceral origin. So sometimes the symptom will mixed up. So if the patient have increased nociceptive visceral inputs, like it's a chronic pelvic inflammation syndrome, then patient can develop the peripheral trigger point, like we can sense or we can palpate the trigger point in the pelvic floor. So remember, visceral somatic convergence. That's the underlying basis for us to do autonomic intervention as the classical procedures. As I mentioned before, so the lumbar, lower lumbar to sacral area, the somatic structure can have the referred pain pattern like it's pelvic pain. So the differential diagnosis, you should always include the spine and the muscular skeletal structure, like we have lumbar facet, lower lumbar facet, we have the radicular pain that mimic pelvic pain, we have discogenic, especially L5, S1 disc, the discogenic pain, the sense, the visceral fiber actually stand up to the low thoracic core. So it's kind of differentiates between pelvic and the discogenic, especially also the SI joint and the pelvic girdle, and also the hip disorders. So always recruit this spine and the muscular skeletal system in your differential diagnosis list. And remember the myofascial pelvic pain syndrome. You can try it out, maybe trigger point injection as small rotator cuff, small rotator of pelvis, or even the pelvic floor. It's the number one target we are doing intervention is the superior hypogastric plexus. Anatomically, it's anterior to L5 body and sacrum. So it's below the bifurcation of common iliac vessels. It's a union of L-tic plexus, L3, and L4 splenic nerves, and they converge at here. So it receives sensory fiber that transmits nociceptive impulse from uterus, cervix, fallopian tubes, bladder, and the rectum. And the visceral afferent with cell body in the DRG of T12 to L2. So they send up the nociceptive input to low thoracic to upper lumbar parts. And it also receives some parasympathetic fibers from S2 to S5. So it's mixed sympathetic and parasympathetic here. So it's the number one target we are aiming. And down below the superior hypogastric plexus is the inferior hypogastric plexus. It's a little bit vague. It's within the bilateral presacral tissue in either side of rectum. So it's ventral to S2 and S3 and S4 spinal segment. It also have contribution from lower lumbar splenic nerves, pelvic splenic nerves, and it send out branch to ovarian testicular plexus, ureteric plexus, and sigmoid colon. So it receives visceral fiber, visceral afferents from the bladder, penis, vagina, rectum, anus, perineum, and the lower pelvis. But they will eventually send out fiber up to the superior hypogastric plexus. So it's actually a continuous structure. In Ganglion Impar, it's a solitary retroperitoneal structure in front of the sacrococcygeal junction here. So it's the end of two parallel sympathetic chain, then they will merge at the most distal parts. It's a treatment target for visceral pain in the perineum area. It's a target for treating the sympathetic mediated pain in the perineum, rectum, and external genitalia. So let's do some classical intervention for pelvic visceral pain based on our understanding of the autonomic system. So the number one target will be superior hypogastric plexus. The classical way to do it, it's under floral. If you do posterior approach, then it's a classical pain intervention. You rotate your fluoroscope, you open up the space, then you get the entry spot here. It's not very ideal, but the patient is tough. So you go a little bit outside, then you skip the L5 root area. Then once you enter, then you check on lateral view, then you go all the way to promontory, then you inject contrast medium. Yeah, sometimes it's challenging, then we can do maybe transdiscal. But if you want to do transdiscal hypogastric plexus block, then you should give prophylactic antibiotics, and you should line up your fluoro perfectly. Then you go all the way down here through cauda equina, through disc, then you enter the promontory area like here, and you inject your medication. Most of the time we need bilateral approach because of the angle, then sometimes we do bilateral entry. But if your needle angle is good enough, you can reach the anterior part, then you can have single injection. But most of the time I will do bilateral approach. And our target is here. As for the inferior hypogastric plexus block, you're lucky. It's a new technique. I haven't published it, but it's very, very interesting approach because we are aiming at either S2 or S3 area. And you remember the sacral nerve roots go outward direction, but the autonomic fibers are in the midline. So under ultrasound, you can have the continuous line of sacrum. Then you find your S2 posterior foramen. Then you do outer plane approach with a lateral to medial needle direction. Then you can actually go this direction. Like, okay, we scan here, then we get the foramen, then we do lateral to medial to insert the needle. Then you open up the fluoro. Then you see your needle direction is lateral to medial. Then you inject contrast medium. So you can easily hit your target here. Because here we have rectum, we have bladder, we have uterus. Don't go too deep. And don't do medial to lateral direction. Then you will hit the sacral roots instead of the plexus. So it's a new technique, never been published. So if you have similar case, please contact me, then we can publish together. Ganglion impar. So the ganglion impar is in front of the sacrococcygeal junction. So I usually do transdiscal approach. Like, okay, I insert a 23 gauge regular needle through the disc. Then after we feel the pop, then loss of the resistance, then we have this. Then we have contrast median spread like this. So it's the classical pelvic pain approach for fluoro guided procedures. But as I mentioned, we are not urologists, we are not gynecologists, and we get referrals from our colleagues. So whenever your patient have been evaluated by your colleagues, so everything is ruled out. Okay, we rule out the intrapelvic malignancy, we rule out the pelvic inflammation syndrome, we rule out maybe, okay, tubal abscess, then your colleagues will refer patient to you. So next, I will share some systemic approach for the pelvic pain, the nerve approach, neuralgia approach. So we are treating pain in the kind of embarrassing area, and the nerve around this area is overlapping. So sometimes it's really tough to do differential diagnosis or to do diagnostic block. So choose your target wisely. So entrapment nerve oriented approach, I would like to cover ilioinguinal, genitofemoral, pudendal, and the posterior femoral cutaneous nerve, the 4 major targets for you to inject or to do neuromodulation. First will be ilioinguinal nerve. The clinical presentation of ilioinguinal neuralgia would be the burning pain or paresthesia over the inguinal area. Sometimes it's difficult to differentiate from the genital area because the pain will extend all the way here, then overlap with genitofemoral nerve. But if the pain is over here, you should think about ilioinguinal nerve first. It will generally worsen with sitting or heavy object lifting or forward bending. And it could mimic the uterine and ovarian pathology because they share dermatome and also because of the visual somatic convergence. And anatomically it will overlap with the genitofemoral nerve pathology. Let me do some anatomy. It emerged out from the anterior rami and of L1, sometimes tiny contribution from L2, and it's highly variable. So the relevant landmark would be the ASIS, the inguinal ligaments, and the spermatic cord, and the round ligament in females. And according to some anatomic study, the course of the ilioinguinal nerve can be so variable. So it's really challenging if you are doing the retroperitoneal parts. The variability exists everywhere. But I summarized some common entrapment site for you. It will emerge out from the runs in between the transverse abdominis and internal oblique in the higher parts. Then they will go out, runs in between the internal oblique and the external oblique. So remember the anatomical structure, then it's spermatic cord here. So it runs here. The common entrapment site, the first one is the rectus border. Like we are doing the acne, you know acne, anterior cutaneous nerve entrapment after abdominal surgery. So the pain will be around the rectus border, and the lowest parts is the ilioinguinal and the iliohypogastric nerve. So the pain will be here, just at the rectus muscle border. And the second entrapment site, and should be the most suitable for you to do injection, is at the iliac crest level. So if you can feel or do some gentle tap, then you feel the Tinel sign here, then it's the entrapment. So it's at the iliac crest part. And for paravertebral entrapment, it's usually very tough to diagnose, and you should do very deep retroperitoneal or paravertebral injection to do the differential, to do the diagnostic block. So it's challenging here. The most common in my practice would be after hernia repair, especially after mesh repair, and the patient will have the ilioinguinal neuralgia around this area. Also for female patient after phalangeal incision, the beginning line incision, sorry, the pain will be around here. So the patient can pinpoint where the nerve get injury. So you tap here, then you feel the Tinel, and then the pain, the paresthesia will shooting down from the entrapment or injury site and all the way down here. So post-surgical ilioinguinal neuralgia is quite common. The diagnostic test always do palpation first. So it's common painful sites around here. So you palpate it, then you do gentle tap, then you feel the patient will tell you where is the entrapment. And usually patient, because they will walk flex. Palpate the 4 major points: the rectus border, the iliac crest, the L1 paraspinal. But to be honest, it's very difficult to palpate, and especially OP scar. And the diagnostic test always rule out, exclude other pathology, like, okay, the patient has no inguinal hernia, varicocele, hydrocele, testicular ovarian torsion, myofascial pain syndrome, abdominal wall muscle, osteoarthritis of hip, entrapment of iliohypogastric nerve, entrapment of the genitofemoral nerve, and lumbar spine pathology. But to be honest, I always difficult to differentiate from ilioinguinal and the iliohypogastric. So I usually do it together, and you can see the ultrasound image, it's just next to each other. So the point of optimal visualization of the two nerve is actually, classically, we do palpation guide. We do palpation-based injection, like, okay, the line connects umbilicus and the iliac ASIS, and we inject here, around lateral 1/3 here by infiltration type injection. But it's in the era of ultrasound. Then we do ultrasound, we see the 3 layers of muscle. It's external, internal, and transabdominis. And you can hear is the iliacus muscle. So the point of optimal visualization of ilioinguinal nerve is here. But it's not necessarily the pathology, it's here, right? But if you want to do any pathology distal to it, you inject here, you can get diagnosis. It's a ilioinguinal neuralgia. But if you want to do therapeutic hydrodissection, then you should do nerve tracking, or nerve tracking all the way from here to here. So you see the nerve, you track back and you track down. Okay, next I will move to genitofemoral nerve. Genitofemoral nerve is more challenging. The clinical presentation of genitofemoral nerve will be burning pain, dysesthesia over the inguinal area with radiation to genitalia and upper medial thigh, because GFN has 2 branches, the femoral branch and the genital branch. Yeah. So for female patient, will possible dyspareunia and the pelvic pain presenting at the embarrassing area. It will sometimes mimic the pudendal neuralgia or even interstitial cystitis. And because it's overlapping with the dermatomal distribution with the ilioinguinal nerve, so sometimes it's difficult to differentiate. The relevant clinical history will be, okay, it's a mechanical compression, maybe in the retroperitoneum, or hematoma adhesion from previous surgery, late pregnancy, especially late pregnancy, it's quite common. It's lumbar plexus pathology, or it's a complication of the previous chemical neurolysis, neuroblock, and the direct surgical trauma. And mostly direct surgical trauma is more common, like it's a cesarean section, hernia repair, hysterectomy, of quite common nowadays is a sling surgery for urinary incontinence. And remember, the patient suffer from urinary incontinence, they have also some pelvic pain syndrome. The anatomy, so it's psoas muscle, it's the iliacus, and it's the spermatic cord is an inguinal ligament, spermatic cord here. So where is our genitofemoral nerve? It comes from the anterior rami of L2 and with some tiny contribution from L1. So that's the reason that behind they have some overlapping symptom with ilioinguinal nerve. It's mainly sensory. It only provides motor branch to cremaster muscle. So if you try to do electrostimulation, sometimes you can see the cremaster muscle contraction and will lift up your testicle. It's funny. And emerge out, runs throughout the psoas muscle. That's the reason why it prompts to the entrapment. If your psoas muscle is too tight, and after emerge out from psoas muscle, it will divide into femoral and the genital branch. And the femoral branch supply the upper thigh, middle thigh, upper median thigh, and the genital branch will go with the spermatic cord and supply the embarrassing area. And of course, variation is very common. So the genital branch goes to lateral part of testicle or labia major and the very upper medial thigh area. And the femoral region, femoral branch supplies here. So in general, femoral branch runs more laterally. It go with the external iliac and finally to femoral artery. So it's usually superficial to femoral artery. It's the spot we are going to inject. And then enter the femoral sheath here. And site of entrapment of the genitofemoral nerve, it's quite challenging, to be honest. So if it's inside the psoas muscle, it's not very tough for us to do psoas muscle injection now under ultrasound. So it could be psoas muscle spasm, retroperitoneal hematoma, abscess, retroperitoneal pathology. Like, I'm a cancer pain specialist, so I have so many patients suffer from lumbar plexopathy caused by lymphoma, sarcoma here. So it's quite common in my practice. And of course, number one reason would be post-surgical, like cesarean section, appendectomy here, appendectomy, inguinal hernia repair, especially laparoscopic. The diagnostic test is very challenging and very difficult because it's always overlapping with the innervation of border zone nerve. So physically, we can palpate the inguinal ring, or we try to do some maneuver to activate psoas muscle, and we do Valsalva maneuver to provoke the symptom. But as for the diagnostic injection, I always do ilioinguinal and iliohypogastric first, because it's easier and it's less risky. And the second procedure I will try out would be ultrasound guided pudendal nerve instead of the genitofemoral. Once I rule out the pain is from ilioinguinal or from pudendal, then we will do the genitofemoral nerve block. But if the very proximal site is desired, like, okay, inside the psoas muscle, or just the retroperitoneum fascia layer in front of the psoas muscle, I will consider CAT scan guided. And I have one case, I even collaborate with the urologist to do laparoscopic to the retroperitoneum and see the psoas muscle. And we do diagnostic injection there. The ultrasound guided technique for genital branch, the target would be the cremaster muscle. Actually, it's the spermatic cord. So you put your probe here. It's a 1 or 2 finger broad lateral to the pubic tubercle and perpendicular to the inguinal ligament. Then you scan here, up and down, until you see femoral artery. And 90 degree to femoral artery, it's the spermatic cord. Then you turn on your color flow Doppler to see the testicular artery. Then you inject inside the spermatic cord. So for male patient, it's sometimes very risky because you could injure the testicular artery and you also injure the vas deferens. Yeah, but to be honest, if you do field block to surround the local anesthetic here, I don't think the effect is good. So I usually go inside the spermatic cord. I usually go inside here and then do local anesthetic or steroid injection. For female, it's less risky because for female, we have only round ligament, but it's the same scanning area. Then we identify the round ligaments. So we just go inside and then we inject. Next, I will move to more important targets. It's pudendal nerve. The clinical diagnosis for pudendal neuralgia, we follow the NONS criteria. NONS is a French gynecologist. The essential criteria will be pain in the territory of pudendal nerve. Yeah, it's very straightforward. So it's from anus to penis or clitoris. And the pain is predominantly experienced while sitting. So the patient will come into your clinic with some donuts, then they will put the donuts on the chair, then they will sit. The pain does not wake them up at the night. And the pain has no objective sensory impairment. Of course, some severe nerve compression, they have nerve sensory loss or sensory decrease, but sometimes not. And the pain can be relieved by diagnostic pudendal nerve block. So for me, any pain symptom involved with pee-pee, poo-poo, and sex, like urination, stool passage, and the intercourse, then I will think pudendal nerve problem first. The anatomically pudendal nerve get supply from S2 to S4, but most fibers comes to S2 and S3. And it's both sensory, motor, and autonomic. So the sensory innervation is in the most embarrassing area. So all the way from clitoris to anus for female. Anatomically, it's the most medial part of sacral plexus. So we see from behind. So we see from buttock, then it's underneath the piriformis muscle. Here we call it as the sacral plexus. Then we have sciatic nerve, we have a posterior femoral cutaneous nerve, we have inferior gluteal nerve, and most medial part runs in between two tough ligaments is the pudendal nerve. So the pudendal nerve actually comes out underneath piriformis, out of the pelvis, then re-enter the pelvis and runs. Then we see from inside the pudendal nerve will run more medial to this muscle. It's obturator internus. And here is the so-called Alka canal. So before entering the Alka canal, the inferior rectal nerve has already out of the pudendal nerve. So the relevant landmark for you to do diagnostic or therapeutic injection will be the ischial spine, the sacrospinous ligaments, and sacrotubulus ligaments, and the internal pudendal artery. When the nerve is difficult or challenging to identify, then we turn on color Doppler to see where is the internal pudendal artery. It's very medial. The site of entrapment, the most common would be in between the two layers of the ligaments. And also from the falciform process of ischial tuberosity is actually here. And ischial spine region and piriformis muscle because it's on top of the pudendal nerve, and obturator fascia, Alka canal here. So it's a common entrapment site. The diagnostic test is sometimes subtle, but I know in the world there are some gynecologists, they are super aggressive, so they do maybe open surgery for it. But at least as a pain physician, we can do palpation, like, okay, even the physical findings difficult, and we can at least find to see if there's a ischial spine tenderness. Also, we should rule out concurrent musculoskeletal pain and arrange MRI to rule out the potential mass lesion. And in my practice, I usually do digital rectal examination or pelvic examination myself. So I can feel the pelvic floor and all the course of pudendal nerve. The diagnostic block, we can do classical. Sometimes I still do the traditional technique. Then I will do pelvic exam. Then I feel the ischial spine. At least we can feel the pubic ramus. Then we insert the needle here, like obstetricians do it before episiotomy. It's roughly the same technique. But most of the time, before ultrasound, we do, okay, it's sacrospinous ligament and sacrotubulus ligament. In between the two ligaments, then we insert needle just next to ischial spine. Then we inject contrast. Okay, roughly the area we are satisfied, then we do diagnostic block. But for ultrasound techniques, more precise and it's easier to do. So we scan from the iliac bone all the way down. Then we see the bone as the continuous line here. Then when we first find the piriformis muscle, then we do hip internal external rotation, and we see the hyperechoic structure underneath the pelvic. The piriformis muscle is the sacral plexus. Then we try to track each nerve. The easiest one would be sciatic. So pudendal nerve is actually medial to the sciatic nerve, and the figure is wrong. The most medial part is pudendal nerve. So it's Yen's publication. So we scan all the way down to see the greater sciatic foramen. Then the sciatic nerve goes out. Then we try to see the bony structural, bony shadow change until we see the ischial spine. Go with the internal pudendal artery, like this. Then we see the two layers of ligaments. So you see laterally the bone, initially it's round in shape, then gradually elongated. So it's the ischial spine. So sciatic nerve is lateral here and medial to the ischial spine. You turn on the color flow Doppler, runs in between the two layers of ligament. It's the pudendal nerve. Easy, right? So the important structure for me to identify the structure would be piriformis muscle and also the sciatic nerve. So here are the small rotators like the gemellus superior, obturator internus, gemellus inferior, and the quadratus femoris. So if you do hip internal external rotation, you can see not only the piriformis, but also the obturator internus muscle, like a trolley moving in and out. Then medial to it will be here is the opening of Alka canal, and above it, in between the two ligaments, it's the point of optimal visibility for pudendal nerve. Okay, let me do some real-time scanning here. So we see here, move all the way down. You get it? Initially, it's so initially it's continuous bone. Then we see the piriformis muscle. Underneath is the sacral plexus, is ischium. Okay. Then you turn on color here, then you can see some vessels, not only internal pudendal artery, but also inferior gluteal nerve and sciatic artery. Then here is the piriformis, is ischium. Then we do internal external rotation to define the piriformis. Then we move further down from here to here. So it's ischium, it's lateral, it's medial. Then you can see the bony shadow change. Okay, so initially it's round, then the bone will get longer and longer and longer, then connect with here. So this spot is ischial spine, and it's the sacral spinous ligament is this layer. You turn on color, then you have the internal pudendal artery. Then you do pivots, you do tiny ultrasound adjustment. Then suddenly you can see just next to pudendal artery, internal pudendal artery, medial, usually medial to it, in between the two layers, it's the pudendal nerve. Anatomically, it's not a small nerve, and we do real dissection, it's huge actually. So the last target would be posterior femoral cutaneous nerve. It also comes with patient have difficulty in sitting. So the clinical presentation roughly will be posterior thigh pain and numbness over this region. So it's around this area. So it's sometimes very difficult to differentiate from the pudendal nerve. Anatomically, will supply this area. So patient will complain pain here and the numbness at this region. Also, we have the obturator nerve supply here. We have the lateral femoral cutaneous nerve supply here, and the PFCN supply here. PFCN neuralgia is quite common in my practice, but it's limited evidence in the literature. And it comes with maybe sometimes mimic with the piriformis syndrome or some ischial tuberosity, ischial bursitis, or surgical injury to it. For diagnosis in patient visit, I will do palpation at the common tendon area of hamstring muscle because it's the #1 site of entrapment. And we should differentiate with radicular pain or pudendal neuropathy and piriformis syndrome. So just do diagnostic block. For diagnostic block, you can scan at the ischial tuberosity area. Then underneath the gluteus maximus and in between the common tendon of biceps femoris and in between the two common tendon, here is the layer, the area of posterior femoral cutaneous nerve, and it runs very close to sciatic nerve. So when you are doing scan, you can sometimes track all the way up to see it emerge out from sciatic nerve. Like here. So you can track all the way up to underneath the piriformis. Then you can see it will gradually, sciatic nerve will move to lateral part, and at ischial tuberosity region, the PFCN, it actually runs on top of the common tendon or hamstring muscle. Okay, when you facing very challenging chronic pelvic pain, sometimes spinal cord stimulation, we have other variant like it's sacral plexus. It's sacral plexus stimulation. It's the antegrade technique. So we do epidural injection, and we thread our leads all the way through S3 foramen to parallel with the sacral plexus. So our society will have this kind of workshop this, I think it's September. Next year, we probably will open for international registration. That's it. So I would like to announce each year, Taiwan Pain Society, we have annual cadaveric workshop. I think it's one of the best cadaveric workshop in the world, because we have each cadaver, we have only two instructor and only 6 participants. And usually it's for 2 days. So you can have many chances to do real practice on our silent mentor. So it's the last year. And this year, because of the COVID-19 pandemic, so we only open for domestic participants in this October. So this time we have all the famous pain physicians in Taiwan. Some of us are already the examiner for FIPP and CIPS exam. So this year we opened for registration yesterday, and it's fully booked within 10 minutes. So if you try to sign up next year, so be quick, truly. And if you are interested in doing prolotherapy, we have an outreach program with the European group, Marcus and Manfred. I and Dr. Jenny Peng will go to host a prolotherapy congress in Linz next year in April. So it's another good meeting you should try to reach. And of course, each year in January, we have the symposium, workshop, and examination hosted by WIP. And we are one of the official sites. So you don't need to fly all the way to Europe or to United States. Just fly to Taiwan and you can get the chance to see all the faculties and train by them and then do the examination. So next year will be January 29 to 30 will be symposium and workshop. And the last day of January will be the examination. So thank you. So it's out my university and my hospital, and you are welcome to visit Taiwan to see all the treasures and all the sceneries. Thank you.
Thank you, Patrick, for that wonderful lecture. It was indeed a comprehensive one, covering all essential parts of the pelvic area. Are you open for question and answer?
Yeah.
Okay. A lot of us here in this forum, except for a few actually, are doing fluoro, and most are doing ultrasound And you have just shown us very important points for guiding us to view those very important nerves that we usually see in our practice, and which to us is sometimes very challenging. Now, since I don't see any question yet, let me just give you my first question. It is very usual for us to encounter patients with coccygeal pain. Can you hear me?
Yeah, yeah.
Okay, so coccygeal pain. So my question is, do you have any clear-cut approach into those particular areas? Because of course, as all of us are physiatrists normally would do, we would subject our patients to some physical therapy intervention, and some would also do some interventional for that area. But a lot of times we don't get a lot of relief for patients suffering from coccygeal pain. So do you have any experience as to how we can actually approach that area?
Okay, so I will show from here. So here comes my approach. I will try to differentiate it's somatic or visceral. Most of the time, actually somatic. So it's like, okay, the sitting trauma or birth trauma that cause damage to the ligaments here and also ligaments here, because the sacrospinous ligament go all the way from medial to lateral. It's the weak part here. So for patient, if I do digital rectal exam to palpate from inside and I palpate from outside here. If the coccyx is floppy, it's fragile, like, okay, you can see clearly on X-ray, the angle it's wrong, and with compatible symptom, then I will try to do first diagnostic block to see if the pain generator is here. Okay, so it's lateral part because it's ligamentous torn or ligamentous injury. But it's super challenging to scan by ultrasound here because we have fat, we have big butt, then sometimes it's difficult to see the layers of ligament. So I just do palpation guide injection, stuck my needle on the bone, then go a little bit lateral. First, I will do local anesthetic. It works for compatible time, and I will try to see, okay, if it's ligamentous injury, then I will give it a try to do prolotherapy like D15, D25. And we explain to patient. But if the coccyx with deformity or with severe pain on my examination, then I will do steroid injection around this area because it's tiny. So we just do infiltration type of things. Yeah. But if the pain, it's a little bit vague, then I will give it a try to do Ganglion Impar. That's it.
Oh, yeah, okay. So thank you for that approach that you have suggested. Any other question? I think I have one here.
May I? Hello? Yeah.
Dr. Thomas. Dr. Thomas, would you like to ask questions directly? Dr. Daniel Thomas? Or may I just read his question anyway. What medication and dose for injection, pudendal entrapment, and others are we use local anesthetics or steroids? So this is for pudendal nerve entrapment. What medication and dose for pudendal nerve entrapment? Hello? Can you hear me?
Okay, yeah. Okay, so I'm an anesthesiologist by training, so I always tend to use local anesthetic first.
Okay.
Because it will build up your patient-doctor rapport immediately. So I will do 1% lidocaine mixed maybe 10 to 20 milligram triamcinolone for pudendal nerve. Hello? Hello?
Dr. Chih, you're muted.
Okay. Oh, sorry. Okay. Do you have any follow-up to that question? No follow-up? Okay.
Excuse me?
Yeah. The other question is how to differentiate pudendal neuralgia and genitofemoral nerve in 1 second. Oh, wow. In 1 second. This is really, how do you do hypogastric from lateral border? Okay. 1 second, Patrick.
Okay. It definitely not ultrasound, sorry. If you want to differentiate within 1 second, you do pelvic exam or you do distal rectal, then you palpate the sacrum at S3 level. And you go out, like you go inside, you palpate here, all the way to ischial spine. If it's a severe tenderness, then it's pudendal. If it's not, it's genitofemoral. So physical is the key.
Thank you. Thank you.
Okay. So any other question?
May I ask Prof. Peng?
Okay, go ahead.
Okay, I'm Istiana from Jakarta, Indonesia. Thank you for a nice lecture. Congratulations, your country is safe for COVID-19. I just want to ask you how to do hypogastric block from lateral border of L5, not intradiscal. Thank you.
You can see here, it's actually the paradiscal or transdiscal approach from this floral image, right? Then you decrease your oblique angle, then the X-ray will more like between midline and the oblique angle. Then you can open up a space around here, this corner. Then you can do paradiscal approach. This one is actually aggressive. It's an intradiscal approach.
Do you have any follow-up to that question?
No, I mean, I want to do it not intradiscal, but from lateral border of L5. How to do it?
Hello?
Yes.
Oh, sorry. Okay, so you try
I mean,
to do
lateral border of L5.
L5.
Not
So
intradiscal, sir. Okay, yeah.
yeah, so from this oblique image, you can do a little bit caudal tilt. Then you insert your needle here. Then you can turn to lateral view. Then you will see the needle is like this direction. Then to here.
Okay.
Yeah, it's difficult to show you on the still image. Maybe you should come to our floral workshop next time.
Okay. Okay, thank you.
Okay, any more question? Patrick, you mentioned about the ilioinguinal nerve symptoms, which is very, very common in patients complaining of proximal anterior hip pain. And you also mentioned about the ultrasound approach for patients like that. But for instance, you have a patient, because this area that you're showing us is also the same area that sometimes the obturator nerve may be also located. So would you mind differentiating this maybe from symptoms that could occur when you are also approaching an obturator problems in this particular area?
Oh, that's a very great question because it's super common. So the pain over here, it's actually the hip joint pain, the most common thing. So I will trace the history and also reserve for the nerve approach as my last resort. In terms of the obturator neuralgia, actually the most common entrapment site is when the nerve emerge out from obturator foramen. Then after it goes out, then they will run in between the two fascia layer of the adductor. So the anterior division runs in adductor longus and brevis, and the posterior branch will run in between the magnus. So I will do fascia plane injection as my diagnostic block for obturator neuralgia, because the pain will be around here and shooting down around medial part of side in the adductor group area. It also, the nerve provides the motor fiber for the adductor group. So the patient will have some maybe weakness or the paresthesia around the muscle area. So the injection part will be here. So I will scan for the pectineus, then the three huge adductor group, do the interfascial plane split injection. Otherwise, I will track the nerve all the way up to the obturator foramen. Then I do injection here. Is that okay?
Yeah, great approach. I think there are no other questions here, unless you have other thing in mind. Although I have last question to ask you. I have this patient, status post bladder cancer patient surgery, and eventually when I was checking the incision, it's a longitudinal incision right at the middle of the infrapubic area. And 2 months after the injection at the surgery, he is developing some pain that actually radiates at the proximal anterior thigh, and then eventually some pain at the posterior gluteal area. And then he has some having fluids that when I checked, there was a lot of fluid in the sacral bursa. And I was wondering, even after maybe 4 weeks of trying to evacuate the fluid in the sacral bursa, the fluid is not actually stopping. And every time I would evacuate, I would get at least maybe 50 to about 80 cc of yellow tinge and blood tinge fluid that's coming from the sacral bursa. I was wondering what could be the cause of that problem, although there was no MRI done. And the patient really is very much like an ilioinguinal type of neuropathy, but with some problems that may be coming from the spine and at the same time the bursa itself. So would it be possible that the bursa in the sacrum will have some, I don't know with your experience, would have some connection with structures that may drain into that area caused by the cancer, or maybe something like that? Hello?
Okay. It's tough actually, but by definition, the bursa is the structural, anatomical structure. We try to decrease the friction between muscles and the musculoskeletal system. But bladder cancer, if it's the classical approach, maybe incision here, then go deeper, it's a inside pelvis. So, okay, I tend to arrange maybe pelvis MR with contrast to differentiate the most possible pathology first. Yeah, but if it's sacral bursa, drainage is easy. Yeah, just for symptom relief, you just do drainage. But to understand the underlying mechanism, maybe we should do more examination, like, okay, you do physical, and more importantly will be image study.
So I think that's all for today. Thank you so much, Patrick, Dr. Chih for your
Thank you.
time. And we really appreciate all the information that you have shared to us today. And hopefully we'll see you soon when all of these challenges are over.
Yeah.
And I know Taiwan is a very safe place right now, but the thing is, we're also prevented from freely flying internationally because of all these challenges that we're having in our respective countries. But thank you for making yourself available for these lectures, and hopefully we can get together in the future once more.
Yeah. Thank you.
Yeah, thank you. And thank you also for the rest of you. And if you would like to review all this presentation, I will post this in the Mask Ultrasound YouTube channel. You can subscribe there and see all the previous lectures for your own purpose of reviewing all these things that could probably help you in your practice, and eventually to refresh whatever information you missed in the process. So thank you, and
thank you,
and God bless, and see you soon. And for the rest of you, see you tomorrow at 1 p.m. in the afternoon with Dr. William Morel from Dubai. So thank you, and take care. Thank you.
Bye-bye.
Bye. Thank you.